All right, dear doctors, thank you so much for joining the session. This is your mentor, Dr. Shahriar. I hope so you can see my screen. Please let me know if you can see the screen and from which city or country you are attending this session. Please let us know. Uh, the great news for your support and participation in the last two classes. A lot of you have been already taken admission. So thank you so much. Few of them, which is I think in last 1 to 2 days, those joined, I think material are yet to dispatch. So I will, send those materials like tomorrow after, because today we have a class and a mock at the same time. So after the live session, we will post that mock. Don't worry, you can take the mock today and even tomorrow. Won't be a problem for you. All right. It's just like, so just take a relax and this, that actually. Yeah. And speaking about the MC new updates, as a some doctor warning, that's one thing is just only thing that can save you in the exam is a good preparation. I'll make an extended video on that one because I'm keep doing research. I'm talking to some of the people who are in Australia at the same time. I know a lot of people because it's been my 10th year. I know even people from Australian Medical Council as well. All right. So after talking a little bit, I will be updating, what's they are up to. Actually, it's like off the book or off the record. I mean, few things, but the question in general will be a little bit. It's not uncommon actually. Every single year, we have seen question pattern changing and this that. The one thing that is universal, I mean, very very important. It is actually that your total knowledge, because what I have seen in last 2 3 years is too much depending on the recall and of people. At the same time, some of the things which is related to more like people are targeting in the exam weeks actually. Now exam week, we also used to do back in 2015 2016, like we used to take a preparation and this stuff, but not we're so dependent on that one that we kept as a little bonus actually. Now even if I have that opportunity, I would even write myself to Australian Medical Council to stop those exam in different days, honestly, actually, because sometimes the real testing, could be exaggerated, actually, even though we are the one who start taking classes on the exam support, but these things dependency is increasing a lot actually, generally speaking. So in my opinion, actually, at least some people should take a decent preparation and then, because if I see the pattern of studies of a lot of doctors, like they have been just doing things of their own, not doing studies like in a group or a study group like what we used to do, and then just depending on a whatever in their mind, or maybe a question bank they are just practicing for a few days, and they're up to just solving a recall course, or at the end maybe a recall support and this that. People keep asking, like in our courses it is already included, the exam week recalls and the support. But if you just start thinking that will be the best way to pass, that would be the most um, wrong decision for 2026. So that's my suggestion to all of you. Actually, the recall dependency and exam week recall dependency. But those of you who are with the good preparation and topic wise, you will study more as like we are going actually, like theoretical important, and it's like a full research of last 10 12 years actually when we make lectures. So this kind of thing will be more appreciated. Okay, and those who wants to take more shortcuts all the time will be in trouble. Actually, I hope this is clear. I think, but I think I will make a video after some more research in very shortly in coming days. All good, guys? Please let me know in the comment section if you are ready. I would say one thing that you don't have to worry too much if you attend classes sincerely, actually. Okay, we have seen much worse days. There was no support, when we used to give exams, actually. Yeah, now with the time, people just keep getting cream and dependency. Trust me on this. In last, those students I've seen, we used to study at least double or triple than them because there was no proper, like coincide things, and then we had to study like seven, eight different books. Multiple things were there actually. Okay, so here is the thing: a lot of people have received email. This of you have opened an account mentioning that the exam will be difficult from next year. The margins can be a little bit changed. Uh, I have seen changes in lot in last 10 years, so you don't have to worry. First of all, mainly they wanted to say that you focus more on your studies. I think that's all actually. Right? Rest is okay. Great. So here we go, and these are some of the. So I hope so. You have seen my YouTube channel, some videos before, and also in the first four class we upload in the YouTube. Then we'll be start posting in the group when we clear the group. By the way, we group cleaning process has been started. So if anyone is also attending today and hasn't joined yet, I think this will be probably the last class in this group for them. Those have already joined, and I think you don't have to worry yet. Actually, great. I'll show you a few page numbers. A quick question: did you see any overview yet? I mean, did I upload an overview or like a guidance? Okay, like mentioning the page numbers actually. So quickly, let's just go because I'll be coming back to this page. It's in John Murtagh. This is the new book page. So if you haven't buy John Murtagh 9th, here is your time to buy the 9th edition. Actually, I highly recommend it. Some people text us for 9th edition soft copy. We cannot provide. We're very big, official like limited company, so we cannot officially, upload John Murtagh and want to get into trouble. So please look around or buy the John Murtagh 9th edition. Other books, soft copies, I think we have provided already. Yet only for the John Murtagh 9th, we have certain restrictions actually. If anyone is using John Murtagh 8th for temporary initial few classes, you can use it, but please switch to 9th edition actually. Okay, because a lot of classes may not match actually, and you will feel bored in that case actually. Of course, there are differences in page numbers actually, and also guidelines. Yeah, so definitely every year. So starting with the page numbers and the topic, we'll go start with the GIT thing, dyspepsia, starting from the esophageal things, the ERD. Then there will be things like achalasia. This is the page number. We'll get into this page numbers already. Esophageal cancer 460. Then we'll get into the other esophageal before the peptic ulcer, that there are like Boerhaave's, like Mallory-Weiss, which is not present in John Murtagh. That's why the page is not mentioned, but that is also included. We'll teach you that one as well. So peptic ulcer disease, then this stomach related, so Barrett's, and then eosinophilic esophagitis. There's another one, and stomach cancers 456. Yes, please go through it. Don't worry, we'll get back to all these topics. Pseudomembranous colitis is a part of like diarrheal things and actually not present in John Burtak, but you do have to study Boerhaave's, Zollinger-Ellison. These are also on a vital topic. Some that are diarrhea related and traveler's diarrhea. Someone travel to a different country and come back and having diarrhea, coming back and having viral flu. These are very popular topics in the exam actually. All right, then there's a very famous one, IBD, IBS. These are some of the topics we'll get through today. Yes, and followed by, so colorectal is more part of the colorectal, like diverticular diseases, rectal bleedings. These are usually part of the surgical class, general surgery, and so we may not discuss them, but we will be discussing the lower GIT. So upper GIT bleed and lower GIT bleed and their causes, at least we'll discuss, and their investigations actually. All right. So here we go. Lower GIT bleed. We do have a note in our note section, so you can also follow that one because it's not present in John Watt. Yes, so these are mostly like are part of our general surgery class. If anyone is in advance interested, you can go to our surgical notes and check them, maybe some of the last pages. Yes. All right. Great. And let's get started actually, guys. Yeah. All right. Are you guys ready? Please let's bring some energy, and here we go. We're going with the GIT theory. It's actually the class will be taken using the John Murtagh 9th edition. Actually, we are using the 9th edition for the class. Very new 9th edition. Just now, Raw came up actually. We are the very first people, I think, started uh, classes on that one actually. All right, here we go with the word dyspepsia 447. I'm sure most of you have already opened it. This is the things we will follow actually. Right. All right. So dyspepsia is like, what is dyspepsia and this, that, I mean, you can understand it's like nothing but indigestion. Generally, just look out the causes because generally you will not get question from dyspepsia, but as a symptom, it will be mentioned like someone is having dyspepsia. Now it can be because of GERDs, can be because of any other esophageal causes, some cases hepatobiliary causes. So it is more as a symptom. So it's not really a question, nothing really to mark. So you'll get in the initial pages of the dyspepsia, chapter 36, by the way. There's questions and these things given. Some doctor get confused. The doctor, should I study these things? Now, see, these are the questions actually for the MC part two, actually. Like when a patient came in, those are dummy patient even though, but we have to ask this question to rule out what is this causes actually. Is it because of GERD? Is it because of stomach cancer or something else? Achalasia. So that's how we go for actually. Now the most important thing is we are going for is a chapter in like in 36 as a GERD. Okay, very very important now to read about the GERD. Great. Overview is posted in batch 65. All the things we post in the batch 65. Sometimes you need to refresh the page. Some pieces, if you don't find, you ask any friend. That's why it is very important to stay connected with one of the friend in this group. Okay, coming to this one, let's get started right away. All right. So the very first thing is coming up. Our title topic is, or what is it? It is GERD. Right, guys? So let's draw a stomach. Let's say this one is normal. Okay. And now let me draw another. Looks quite similar. It's quite similar, but this one looks a little bit more relaxed. I mean, this particular area, the sphincter wise and otherwise. So there is a thing called backflow of acid. And this has a name actually. There is a term for this one. What is that thing is called? We call it in medical term regurgitation. Now the question is this regurgitation is comfortable? Now this is very uncomfortable. Okay, uncomfortable, and it gives rise to, your heartburn. Now heartburn is a very important title topic because in GERD you are expecting heartburn, but in achalasia versus achalasia, you know, achalasia cases, usually no heartburn. Am I right, guys? In achalasia cases, usually there will be no heartburn. That's most important. Great. Achalasia cases, no heartburn, actually. Very, very important differentiating point. Can you add some more points? Now, for that one, I will show you something from the John. Now, other than that, maybe some of you already, if anyone is obese here, you might also have some ZERD features, right? So there is a things like bloating, heartburn, especially at the night time, there is some uh, distaste in the oral cavities, and some cases at the night time there will be symptoms. So that's why we ask them to use double pillow, right, guys? Double pillow for ZRD cases so that this acid reflux things at least a little less. Some cases. Here is a thing, red flag pointers for ZERD actually. Like, see, if ZERD with anemia, ZERD with dysphagia, are this good news? Not really. So, if ZERD with achalasia, sorry, ZERD with anemia, dysphagia, what is it indicates actually? Any idea, any cases? ZERD or ZORD with dysphagia features, is it always common? Not really. How many ZERD you see? Many. But how many dysphagia you see with ZERD? Very, very less. So if associated with, dysphagia, this ZERD, it is probably an indicator of cancer. Now you will need a further biopsy. So this brings us to the point, let's coming back here. What is the general investigations? This is very, very important, guys, to know about uh, this kind of things like for the AMC exam. AMC is very, very interested to know about the investigations, especially like initial, some cases next, and some cases best. Now we have these things here. What is the initial? Remember one thing, every esophageal cases, it is a barium test. Every esophageal cases, it is a barium test actually. No matter achalasia, no matter GERD, no matter cancer, no matter nutcracker, no matter any others. We always go for barium. I hope that's clear. Next thing is coming, the which one is like a best to diagnose is ERD. Have you heard about 24-hour pH monitoring? Because it's an acid, so you can actually check the pH thing actually. So 24-hour pH monitoring. Now, what is that unique test you want to rule out if there is a associated with dysphagia? What is that additional test you want to do if it is associated with unique things like dysphagia? I means if there are like red flag pointers, if there are like a red flag. So in that particular case, we'd like to go with the endoscopy, endoscopic biopsy. Endoscopy, upper GIT endoscopy is the right term. Is it clear the investigation when it is initial, when it is best, when it is actually the unique, especially endoscopy, we do it, especially when there is a red flag signs actually. And what are those red flag signs? These are the red flag signs like anemia, because they're probably a bleeding, or they're probably a obstructing thing because of a cancer. So we need to rule out by doing an endoscopy in that case. This kind of thing I highly recommend. If you use a small ballpoint pen or a pencil or whatever, you can write these things here in this way. Some people also use a diary. In our class later, they transfer these things in the John Murtagh. But if your writing is a bit decent, I would recommend you if you write into your John Murtagh, it's more recommended actually. Okay, so that's the thing. Yes. It's not an order, but normally it's a barium, then it's followed by uh, not as like the respiratory. Normally, you can skip the endoscopy unless red flag pointers. Okay, I mean, let's write in that way: skip endoscopy unless red flags. Now clear? Normally, endoscopy is not a part of this particular endoscopy is a test mainly for the esophageal cancer. Is it clear, everyone? Endoscopy is a mainly a test for esophageal cancer, but when the red sign came up, now this brings us to the point, a case of GERD, will there be possibility of any um, situation if there is a chronic acid reflux? So this brings us to the point, is there any possibility of complications, dear doctors? Is there any possibility of complication? If that is a yes, so what are the consequences and complications of a GERD cases? GERD, we have a SMA note in our note section. You can also check that one. Let's bring to the point. First of all, because of the esophagitis. Esophagitis. Number one, because irritation. Okay, because of this irritation. You can also add the word irritation actually, or that's the thing. Then if it is more chronic, it's keep happening. Is it possible to get into a situation? Barrett's. We all heard about Barrett's. Isn't it that a pre-malignant condition? Yes. Barrett's is a pre-malignant condition? Double-edged sword? Yes. Okay, we'll get back to the Barrett's. Any other thing, is it possible? Because of reflux, and this reflux thing. Any other complication, is it possible? Yes. There's some other issues because of chronic irritation. This particular area can be like a burnt kind of like a. So, is it possible to have a stricture? Yes. Again, it can be possibility of having a stricture. Yes. Okay. So, esophagitis, irritation, Barrett's, and even stricture. Even this stricture can lead to some sort of obstructive features in future. Also, you can add this thing, anemia. You can also add that one as an anemia. Okay. Uh, as an associated feature, it's not a complication. Is it possibility that 30% of the cases can have asthma? Did I mention in past actually? I mean, there was a respiratory class we mentioned with the asthma. There can be relation with the GERD. So you can also compare and contrast now, right? Now, coming back to the more things, I mentioned the GERD. I'll be talking a little bit more about the Barrett's. Barrett's, by name, it's the Barrett's esophagus. So it's a area wherein the esophagus, now let's draw it a little longer. Yeah, so because of this acid reflux, this area is irritated, and eventually there is a cellular changes. Cellular changes. Now, question is cellular changes are good? Quick question. This one has a lining epithelium. This one has a separate lining epithelium. Now, this one's like a stomach's lining epithelium. If you put into esophageal area, is that good? No. These cellular changes are not good. That can be actually metaplastic change. Am I right, guys? This can be a metaplastic change and not good. So initially it can be pre-malignant condition. Later it can be uh, malignant condition. Now this brings us to the point adenocarcinoma. Did you ever heard about this name, adenocarcinoma? So for remembering purpose, because it happens often in the lower one third, right? Because it's irritation, irritation, irritation. So we remember this thing as a mnemonic one third AB. Can you see if you can correlate lower one third of the esophagus, adenocarcinoma because of Barrett's? Cool. Another thing to remember, BCS. BCS is a kind of like a entrance exam in our country for government jobs, right? Anyways, um, I remember this thing in BCS as a in Barrett's. You can also write same way in Barrett's columnar replaces squamous. I repeat, in Barrett's esophagus. I mean, in Barrett's columnar replaces squamous. So usually the lining is squamous, but here it is columnar. So is this good? Again, no, it's a metaplastic chain. It's bad. Most important thing in Barrett's you need to know is a type of the cancer for AMC, which is adeno. Another very important thing to remember is about follow-up of Barrett's. We make the diagnosis, of course, we need to do endoscopy and the biopsy, but AMC will ask you for the follow-up. Now, let me take you to the esophageal, the Barrett's area now. So you enter into Barrett's without asking. It's a part of the GERD. So consider 2 yearly endoscopy, 454 page. Please highlight this thing. A 2 yearly endoscopy and biopsy following up is very, very important. As a treatment, you give PPI and other symptomatic things, whatever necessary. Okay. Is it clear about the Barrett's? I hope it is. Now we are coming back to our GERD again. Now, how to treat a case of GERD? I'm sure most of you in your life have given treatment for GERD for someone, right? Like someone is obese, someone is getting older. That's quite a common of having GERD. Now, in that case, very important person is overweight. We start with the lifestyle and first of all, as a long-term treatment. So this is an exam question again. Please highlight this reduce weight and write the word near to this long-term. So the long-term treatment for GERD, I repeat, long-term treatment for GERD is weight loss. Then few other things, adjustments, avoid fatty food, take more fiber, eat slowly, okay, so that you don't have more bloating and this that problem. Certain drug can gives you more trouble. I also highlighted that one again. And using elevation of the head using probably double pillow. This is the early, the most important is the lifestyle. Many cases, it's not enough. The patient keep complaining and now a trial PPI. This brings us to a very important MC question. Would you like to go for a barium test first? Or would you like to start the proton pump inhibitor first? This often confuses our doctors in the main exam. PPI or yeah, test. First you go for a PPI or first you go for the answer. It's a trial PPI often called. So you don't go for a test, barium or endoscopy or those things. So we start often, that's why when I was intern doctor, I used to see a lot professor was giving PPI for 1 month. I used to think maybe they have some connection with the, those pharmaceutical companies. They are giving 1 month of treatment because professor, they never used to explain anything in any way. So yeah. So later, when we understood treatment and they said, oh, okay, like normally GERD cases, at least like a 1 month, you continuously, because as an explanation you give to the patient, see, your acid regulation is not good in generally, and there is a reflux often. So with lifestyle and with drug, both you need precautions actually. So suppose like only lifestyle and this thing, but many people after using the lifestyle, it's not enough. So that's why they need also the PPA and the trial PPA. Now, if PPA 20 is not going well, we can convert into 40, right? This is the thing. So 20 is converting into the 40 alongside lifestyle modification. There will be thing in the surgery we'll learn more. Hiatus hernia. There will be two type of hiatus hernia. Why this word hiatus hernia coming? We talked about some of the complications earlier. Yes. One of them you can also add here, perhaps this word hiatus hernia. Significantly obese people in hiatus hernia cases. So there will be two types which I will tell you in surgery. One is a sliding and one is a rolling type. So you can see this is the diaphragm and some part it's quite an above actually, as you can see. Okay, so sliding and the rolling, these two. And their treatment, very interestingly, also PPI and weight loss. Again, hiatus hernia treatment, PPI and the weight loss. If all medicine treatment failed, it's surgery. All medicine treatment failed, it can be surgery. So yes. So weight loss, this is surgery for when medical treatment failed. Or rolling hernia, if for repair you might need, especially this one. Yeah, see, this one is like quite invaginated. This one is like you can lose weight and other things will give you relief, but rolling probably not. So rolling cases probably need a surgery. Great. I'll ask you a Q question. I'll ask you a Q question. Oh, someone asked me a question about conversion. Conversion 20 into 40 as an initial PPI treatment. Okay. Generally, is dyspepsia related? Which dyspepsia is common? Peptic ulcer disease, esophagitis, esophageal, all problems. Which one is number one common? If patient is coming in and talking about dyspepsia, I have discomfort and this, that. Because for AMC, it is very important to know the MCC. MCC means most common cause or most common. So number one cause is not ulcer. It's actually non-ulcer dyspepsia. Now, see, you, me, everyone probably in our life, we probably, at least at any time, we probably have, because we are all medical students in past, now doctors, our lifestyle is always not that good. So we sometimes, there's like a indigestion and some, this thing has happened, isn't it? I think everyone's life it has happened, but do we have ulcer? Probably not. It's actually the non-ulcer dyspepsia because if you're stressed, if your lifestyle is not good, for example, during the final professional exam days, your MC is coming those days. Okay, so the non-ulcer dyspepsia chances are very high. Again, same thing, you lifestyle modification, removing the stress and give the PPI again. That is the treatment. Okay, so coming to the point about the GERD. Are we clear about the GERD related thing? Are we clear about the GERD related thing? Please let me know in the comment section. Please let me know in the comment section. Actually, is GERD related? Everything is clear. I'll give you a second. I'm double checking as well if anything is left. I'll probably show you a slide which I use for SMA note as well, collecting from the Davidson and some of the personal notes. Yeah, so this is one. Okay. So you see this keyword lower esophageal sphincter, relaxed sphincter. So this sphincter area is often relaxed. That's why the acid leads to injury, acid leads to Barrett's, acid leads to nocturnal symptoms. Okay. Yes, someone asked this question, PPI before barium. Yes. And you see this, they highlighted heartburn thing. This heartburn can feel like a chest pain. Did you know this information that 40% of the chest pain, which you think as a um, heart attack, eventually turn out to be 40% cases as a gas problem or GERD problem, right? That's the thing. Yeah. Achalasia we are going with, so don't worry. I'm just showing this slide one more time. All right. Coming back to this slide. So officially we have gone through this slide. One more last thing to add here. I think I will add that one in the esophageal cancer cases as well. So we mentioned only about the lower one third. What about the upper two third? Upper two third is small cell cancer. More common. Okay. This is also important information for AMC exam. Lower one third, uh, adeno more common. This is also important for AMC. Moving forward to the next topic. GERD is done. Non-ulcer dyspepsia, we just mentioned. Barrett's, we have highlighted. Yeah. Next coming, we will be jumping into another chapter. Later, we'll come back to peptic ulcer because it's a stomach problem. Let's finish the esophageal things first, actually. All right. Some people, when they question, if you know the answer, you can also write it down because some people just miss some part while hearing. Please help them in the comment section as well. Okay. Next, this one after 36, there's a 37 dysphagia because dysphagia is somewhere related to our esophageal thing. So there's two terms I wanted to highlight here regarding this particular thing. And one of them is the dysphagia to solid and dysphagia to liquid. Now, tell me about dysphagia to solids. Can you give me some example? Okay, cancer. Someone is saying cancer. Yeah. One more, stricture. Yes, so dysphagia to solid, this one is important. Dysphagia to solid. And dysphagia to liquid. Now, this is interesting. I know all the motility disorder, particularly achalasia, or you can say other motility disorders. Okay, so this is the basic you need to remember for this chapter. See, John Murtagh book is designed mainly for the GPs. It's not always designed for the uh, AMC takers, but I'm trying to prepare you because questions are made from here, and also someday you will go to under a lot of supervisor. And mind it, those been through our academy, they always been praised. Yes. Yeah, I met a doctor last time when I went. I said, like, your students are really good. And really, sir, yeah, you teach really well. I mean, they give a lot of good references. So I feel very proud of them. Great. Now, dysphagia to solid, dysphagia to liquid. Here's few informations are given as a nice to know. Maybe you can read one time. But initially, if you want to highlight, this box can be useful for you. But mainly we need that information, dysphagia to liquid and dysphagia to solid actually. This is a unit to mark it, page number 459, ninth edition. Uh, Dysphagia to, yeah, red flag pointers. Now, if you have dysphagia, it's maybe a suspicion for a cancer, some cases. Mind it, patient can fake it. We call it globus. Have you ever heard this term? Uh, globus, globus or globus hystericus. They feel like something obstructed in their throat or something, fish bone or whatever. So, but actually there is nothing. So it's often called globus. I haven't seen in MC, but in real life we practice that one a lot. Okay. Next coming is the two things related to esophageal condition. Let's deal with the achalasia first, actually. Okay, so let's go with the achalasia first, actually. All right. Please let me know if you can see the screen well. Yes. Okay. Don't worry. Looks weird, but I'll get it right for you. Previously, I have drawn a esophagus which was normal, right? Then I draw an esophagus earlier where it was like a kind of like a lax sphincter and this that. It was GERD. Now I'm drawing an um, particular uh, esophagus with the stomach, mentioning this part is quite tight. Now, the big question is in achalasia cases, are you expecting heartburn? I repeat my thing. Achalasia cases with a tight sphincter, which is opposite to GERD, are you expecting heartburn? I want everyone, I mean, let me tell you one thing. Those participate more in classes, they really do well in the exam. So some of you, one, you can keep sitting and listening, or some of them participating, they feel more motivated. Then they are more motivated in studying. Yeah, so please always try, always do that. I always encourage that. Now, with the tight sphincter, because there won't be acid reflux like GERD, so there will be no heartburn. Up to this, I think everyone is clear. Okay. Also, in this one, no dysphagia for solid as like previously, but in this case, dysphagia to liquid first, then followed by both solid liquid. Is this clear? So normally dysphagia to liquid we understood motility disorders and this achalasia things. Dysphagia to liquid first. I hope that's clear to all of you. Now, if I go into a little bit more pathophysiology, which is usually not part of the AMC, but sometimes fun to study. I promise you guys to make a little brain. Now, in this case, if you see, these are histological section, like initially mucosa, then comes the uh, submucosal area, then like followed by other. Lastly, there is like a serosal. No, mucosa, then there is a submucosa. Did you know this information from MBBS level or maybe you forgot? There is a thing called myenteric plexus. If your answer is a yes, please let me know in the section. Submucosal area containing myenteric plexus, and this myenteric plexus is responsible for your peristaltic movement. I repeat, submucosal layer, myenteric plexus, responsible for peristaltic movement. Now, what if this submucosal plexus or areas or this myenteric plexus has some problem congenitally. Like a kid is born and myenteric plexus is not uh, in good number or underdeveloped. Do you think there will be proper peristalsis? Answer: there won't be uh, good peristalsis. So the peristalsis is important for the food to from the oral cavity, then esophagus to stomach, go into the anal canal. Okay, so especially for the liquid is even more important. So that is one of the reason because of this mind tree plexus thing. Uh, yeah, so mind tree plexus thing known as also Orbeck is mentioned by someone. Uh, there will be this problem of taking the food, especially the first quickly noticeable with the liquid foods actually. With liquid we take more than the solid. So it is more notifiable with the liquid actually. Is it clear, everyone? So with the liquid, it is more available. There's another acquired cause, which can be there is a disease called trypanosoma. Maybe you read in the microbial trypanosoma cruzi, bruzi, rangeli. You don't have to remember. You don't have to remember. Uh, so again, the trypanosoma can affect the submucosal. Again, if submucosa affected, mesenteric plexus affected. If mesenteric plexus affected, then there is a peristaltic problem. All you need to remember is if mesenteric plexus affected, can lead to peristaltic problem. Up to this, if you remember, it's fine. Actually, you don't have to go to that much pathophysiology actually. All right. And if you have this African area related trypanosoma, again can have this acquired problem. So for kids problem and some cases congenital problem. Okay. So this can leads to achalasia. Let's not go into more deep. There's nothing really mentioned here. So it's a motility related problem. Now, what problem are we expecting? Discomfort? Yes. Dysphagia to liquid? Yes. Now, the quick question comes here. What test you want to do? I repeat, what is the test you want to do in this particular cases? So, test related to achalasia. Investigation related to achalasia. Initial. Initial is always the universal, that is the barium. Now, what is the confirmatory? What is the best in these cases? There is a term called esophageal manometry. Maybe you heard this name. Manometry. So barium, universal for all esophageal conditions initial. And there is that particular thing that is called what? That is called the barium. Everyone clear? Everyone clear about this? Up to this, everyone clear? I hope it is. So let's see. So symptoms given, dysphagia given. You can write one term, particularly no heartburn in achalasia. Write it in John Murtagh. Yes. The manometry is the only way to diagnose it certainly. Very important, it's their treatment, which is not very clearly given here. Let me tell you the treatments. Okay, let me tell you the treatment. If anyone knows the treatment, can also participate here. So treatment related to achalasia. So I'll divide into first, second, and third. First and second is usually the medical treatments. This one is a surgical treatment. Okay. What you can do initially? See, your sphincter is already like a tight, quite a tight. So you need to make it loose. So we start with conservative. Now into that conservative, what to do? Yeah, relaxant is a good idea. In a conservative, see, we always start with the drug things actually, like let's say some calcium channel blocker like nifedipine, CCBs, CCBs. So as you can see, there's the option CCB. Did you heard this thing that there is a thing called Botox or botulinum toxin that can help dilate the face so that the wrinkle thing does not show up? Did you heard this kind of thing? At least Botox, I'm sure you heard. Make it like a more dilate so that the wrinkle thing is not. So the same concept is kind of used here. Like it's actually this Botox or botulinum toxin, so that can be also used as a like in the first actually. Now, next thing you have to be more aggressive. So this is more like a soft treatment, and more aggressive treatment is like a dilatation, right? Next one is more like a dilatation. So we use dilator. It has a name, so Hellers. Heller's dilator. So of course, you take a bigger things, you try to dilate it actually. Safety things. When using dilator, can it be dangerous? Using dilator, can it be dangerous? Some cases. The answer, yes, the dilator can be dangerous. Some cases it can lead to perforation, some cases. So you have to be careful actually. Last but not the least, last but not the least, there is this surgical thing. So AMC will ask you a lot of type of things. One, this one can be asked, this one can be asked, this one can be asked. Also, some additional question can be asked. What are those? Uh, Most effective treatment. But don't get biased with their word. Most effective treatment for this one. Answer actually is a surgery, and this is a MC question. Even though surgical mortality rate is high, but when the question is asked, what is the most effective treatment, and surgery has been mentioned, surgery is the most effective treatment. This is not universal for this condition, but many other condition, similar like this, surgery is the most effective treatment. Okay, like let's say someday in renal system and also in the gynae, compare contrast I'm doing, there will be incontinence, stress incontinence. So again, there are conservative treatment and most effective is surgery. So those type of questions comes often actually. So incontinence related question comes in MC. Most effective treatment is surgery. CCB stands for calcium channel blocker, my dear. Nifedipine, the drug. All right. Great. I hope that's clear. Is all the things, the drug, treatment, conservative treatment, and the other things. This brings us to the point after the achalasia, esophageal cancer, right? Uh, Let me know if my uh, teaching is, you can understand and you can coincide everything. So far, okay, everyone? All right. Next coming thing is this esophagus. I'm drawing and again highlighting lower one third, upper two third, because we're going to talk about now cancer of the esophagus. First, start with the most common question which is asked in AMC. AMC will ask you most common cancer of the world. Most common of cancer in Australia. These are the two most popular questions. First of all, actually, if I look into the geographic things, this one's answer is a squamous cell cancer. Whereas for Australia, as per the RSCGP, there is a adenocarcinoma. Adenocarcinoma. Great. I'd like to update maybe in a next class. I recently got some update regarding, uh, see, John Murtagh didn't mention that one clearly, but I was checking asthma handbook. There's few guidelines: asthma, AMI, stroke. There's three, four things. They keep changing every year. Uh, if you remember last year, I mentioned less than 5 years, as a preventive, right? There was, we recommend the SCG, if you remember, talking about this asthma little recapping. I saw another chart in the asthma handbook guideline. ICS also has came up actually. All right, so now this is new, but I will update you guys after a little double checking that one actually. That even before the 5 year, they give a chart, and in that chart they also mention the ICS instead of the SCG. But John Murtagh didn't mention, even it's a new one, but didn't mention in that way. But we also understand asthma handbook guideline in Australia is the most latest thing actually. So that is probably a very latest guideline in last, I think, in few months, whereas John Murtagh is probably released for 6 months and the editing is happening for another maybe 1 year. So probably this is like a very recent update according to the handbook actually. So keep it in mind, keep reading that one. Maybe at some point I'll update you on that one. Okay, so I'm just putting thing in your mind in that way. Great. All right. So starting with that one, the cancer thing, the esophageal cancer. By the way, esophageal cancer related note is available in our note section. Now, esophageal cancer. Let's get into it. Okay. Most common is 95% generally, whereas adeno is for Australia more common. Uh, Next important thing, see, any esophageal condition, it's barium, but endoscopy is a very perfect and most unique test for ruling out cancer. So we need to do endoscopy. So if you see anything red flag, always go for a biopsy. We don't have to wait for the other results actually. I hope that's clear. Okay. Another important information, Dr. What about CT, MRI are not enough to diagnose esophageal cancer. So you need biopsy definitely. Cancer cases, you will get dysphagia problem, very unique. Age group is of course after 50 years suspected more. Dysphagia for solid. You need to do PET scan as like many cancer cases if like a distant metastasis. So look into PET scan actually. So treatment depends always on the staging grading these things. So if grade one and two, um, in that case, uh, you can do surgery. So surgical resection always things to try. So like you can add this line grade and one and two. Also depends on location. See, two areas. Remember this anything. Two areas. Every surgeon they don't like to operate always. One is this esophageal area and one is the pancreatic area. Very high mortality rate. Remember that thing. This esophageal area and that pancreatic very high mortality always, and followed by some cases surgery not possible like stress 3b or location or health status, cardiac status, respiratory state, many statuses included. Extreme elderly fragile patient can't go for surgery, so in that case chemo radio can be also an option actually. Yes. Okay, also stent replacement can be done. Is used for the lesion that cannot be resected surgically just to keep the esophagus open for uh, yeah. The patient will be present not only with dysphagia, but also with hoarseness and the cough. So patient will be also present as a hoarseness cough. Hiccup can be an early also sign. I repeat, hiccup can be early sign. Let's see a scenario. 60-year man who is alcoholic in past. Mind it, alcoholic smoking can contribute. Difficulty in swallowing for solid. So very clear view. Progress is to difficulty swallowing to liquid. So initially solid, then both problem. Smoked like 2 pack. Those smoke actually like a 60 pack always have higher chances of any cancers for last 35 years. So those 20 cigarettes for 20 years is a very high risk. In addition, he has a progressive weight loss. So very clear, loud and clear view for any cancer develops like weight loss and weakness. So types of cancers, tests, and the clinical features. So that's something for the esophageal cancers. That's something for the esophageal cancer. Weight loss can be very important thing. So dysphagia, weight loss, some of the other features, areas are important. Already we discussed Barrett's esophagus, which is related to lower one third, can also develop adeno. This is also part of that. Okay, everyone clear about the esophageal cancer thing, guys? Everyone clear? Cancer one is was a easy one, I guess. Additional thing what you can learn is a risk factors separately, guys. Those are like some of the popular diseases. Try to read about their risk factors, especially the cancer ones. Okay, so maybe you can Google it later. The what are the risk factors, or maybe bigger risk factors for esophageal cancer. Here I would say it's more about the smoking thing. I want to highlight more actually because they have highlighted the smoking things. Yes. Great. So esophageal cancer. The last slide I show you, that one actually from the Master the Board book. There's another medicine book available called Master the Board. So yeah, so Master the Board book actually. It's more for like a USMLE base, but it's a nice punchy one. I'll introduce you with many things actually. Yes, no worries, guys. Good question. Can uh, GERD can lead to cancer, not actively. GERD eventually can lead to like Barrett's because of chronic change. Because of that chronic change can lead to cancer, right? Great. All right. Coming to the point. So three things are done. Now we are going into one more important, eosinophilic esophagitis. Before going to that one, we discussed about the esophagia, difficulty in swallowing, and painful swallowing is another term because of candida, because of burn, because of zoster. Yes, because of GERD, some cases it is possible to have odynophagia as well. So please keep it in mind. Not a MC question really, but you never. Coming to this one, which is actually popular in the exam, is actually eosinophilic esophagitis. Eosinophilic esophagitis. When the word eosinophilic is there, what do you expect with the word eosinophilic? Allergies, because eosinophil raised when there is allergy. Are you expecting this thing as a chronic disease? Yes, it is. Please highlight the word chronic. Are you expecting IgE level elevated? Yes. Are you expecting any atopy? Atopy means like allergy are like brothers. Allergies are like bhai. It's kind of like that. So in the family, it runs actually the allergy thing. So someone who has maybe other family member having asthma, one family member can have eczema, one family member can have eosinophilic esophagitis actually, or mother is having one allergy, kids are having other allergy. It's not an uncommon thing. Great. So this brings us to the point. How would you like to test? So initially it's a blood test, of course, and you can also do the barium and you can also do the endoscopy. As we mentioned, esophageal any cases, we do the barium. But in this case, you also need gastroscopy or endoscopy. And endoscopy, there will be, constrictions actually. You can see multiple constrictions. It's not written here, but you can write it down. Gastroscopy or endoscopy will show uh, further. Let me show you that one. One second. Sorry for switching over. Here we go. So barium solo usually initial and narrow esophagus, and there will be multiple constriction. You will get to see in the gastroscopy. And of course, in the blood, allergic things, IgE, eosinophil will be shown. And as per the John Murtagh, definitely you need to give something for the allergy. And if serious, of course, you need to give, steroid in that case. So ultimate treatment is the steroid in this case. So if you take a special history, there was another question that they give a scenario of eosinophilic esophagitis, and they ask question in that way, which of the following it can be related to? One of the point was given, there is a history of food allergy. Now, do you think it can be a right thing? What do you think, guys? Is it possible? Like can it be a right thing? I think answer is a yes. So it can be uh, disease related to food. That is possible. So more thing, disease related to food, then affect children and adult both. It can be because allergy can start from early associated with other allergies. IgE symptom improves within symptom removing. So first thing here, withdraw the triggering thing. Withdraw the triggering thing is the triggering food here or any triggering thing you need to remove it actually. Okay. So buscopan solid corticosteroid, investigation barium, and gastroscopy means endoscopy, dietary corticosteroids, buscopan. Okay, everyone clear? I hope it is. Initial is a barium, my dear. as like other conditions, all esophageal condition, barium. As supports, you can do IgE, blood test, and all other things actually. X-ray in terms of making a diagnosis can be important. Some X-rays can be making diagnosis important. I'll show you some of the barium pictures, my dear. Yes. Diagnostic thing is a gastroscopy or endoscopy is the main test, diagnostic test. Okay. I hope that's clear. All good, everyone. Okay. So we learned fitting. Here is something we highlighted. Infective esophagitis in HSV it can be. And now there is something I wanted to highlight. Uh, yeah. Two other condition which is not given in John Murtagh. Oh, okay. This doctor came to meet just few days back, got a job and left actually. Anyways, yeah, I wanted to show this one actually. Okay, so this one I want you to take a picture first of all. This one may not be added to the SMA note. It's just we made it. Plus, first have a look, then I'll be explaining it now. Both of them are esophageal condition. Both of them can be related to forceful vomiting after incidences like a parties like this, that. Especially both of them can be related to binge drinking. Do you understand what is binge drinking? I'm sure you do. Maybe um, those people go to say parties and drink a lot alcohol. So that's something we call binge drinking. If you're going to practice in Australia, which is different, so binge drinking things are very common. So after the binge drinking, there are a lot of pressure on the lower esophageal side, and that can lead to forceful vomiting in some cases. The full thickness of the wall can be ruptured. Imagine in cases of Boerhaave's, the full thickness of the esophageal. Now, do you think this can lead to mortality? Please comment in the comment section. If full thickness of the esophagus ruptured, imagine how dangerous. So it will bleed out. It will also feel like severe chest pain, breathing difficulties, definitely require immediate medical attention. So, in between Mallory-Weiss, Boerhaave's both are dangerous, probably Boerhaave's even more dangerous. One more thing I want to add, Boerhaave's can be related to even pneumothorax as well. Please, this is a special line. Boerhaave's can, next in the recall class, I'll show you. Boerhaave's can be related to pneumothorax as well. Very important information. Let's focus into the Mallory-Weiss, same kind of thing, but maybe a little less severe. Why less severe? Because full thickness is not ruptured. Whenever your esophagus thickness ruptured, you can imagine what can happen. So much bleed. So results in bleeding here as well. Hematemesis, melanoma most cases, but full thickness ruptured, I mean internally bleeding, this that thing can happen. This one can be managed or can be observed, but this one you need immediate surgical repair probably, but emergency. This Boyd House is a real emergency. Whereas Mallory Weiss is always not an emergency. Okay, and even prognosis is good, whereas Boyd House prognosis is quite bad. I'll give you 10-second more time. You can take a picture of this one. This one is, I think, not added in the SMA note, so it was freshly made. I'll show you a picture of Boyd House if you're interested. See, there was a recall question. I brought that one for you. A conference meal. You can tell binge drinking or a conference meal, both will put a lot of pressure on the lower esophagus. That's the main thing. Sudden pain in the, so it will feel like a heart attack. He has got a heart attack before as well, so it can be confusing. After resuscitation is the most appropriate test. So resuscitation, often this word is common, means IV fluid and all this thing. What test you want to do? So there's a bunch of tests are given, but if you see lateral chest X is important. Why? It's because in a Boerhaave's cases, it is noticed. If you see, this is the trachea. Can you see that? Is the tracheal deviation? Yes, massive deviation. So in Boerhaave's, actually there is pneumothorax is possible, and that is the reason the test doing the X-ray is important. Doing an X-ray is important in Boerhaave's. Right? I hope that's clear. So Boerhaave's and the Mallory-Weiss. Boerhaave's and the Mallory-Weiss. One more time. So these are the two additional things which is not given in John Murtagh. John Murtagh, sometimes we say John Baba in funny way actually. He passed away, I think, this year. I think 2 months it's been. I'm sure you know that actually. Yeah. So after, I'm not sure about the 10th edition updates, but some other will. I mean, same goes with the edition. Other authors are updating it actually. That's one of the main book. Right. All right. So this is probably the end of the esophageal problem. And now some of the other things will come up, that like stomach related problems, then gastroenteritis, malabsorption, diarrhea actually. Okay, great. Uh, if you're okay, can we take a break here? I mean, we just finished the esophageal. Yes. And then I think let's come back and clarify the things. Okay. So when we come back, peptic ulcer coming up things. Yeah, peptic ulcer disease, non-ulcer dyspepsia, bleeding, very important. Even this November and October, I see bleeding peptic ulcer coming. H. pylori treatment, so important. Yes, stomach cancer. Yeah. So we'll be discussing this actually shortly. All right. Uh, what do you think? GIT is little more fun than respiratory, or respiratory was more fun? What do you think, guys? Let me know in the comment section, actually. Yes. Even though I myself like belong to respiratory side, but I think GIT diseases are more fun to study. Others actually, some of the other conditions you'll find a lot interesting. Renal, then endocrine, and then rheumato, of course. Actually, yes, uh, yes, yeah. So, anyways, let's okay, maybe someone like neuro as well. Yeah, neuro. If you understood, then it's really good. If you don't, then it's very bad actually. I also found cardio is also not bad, but our doctors are having a lot of hard time when we started actually cardio. Actually, cardio, everyone is pissed off normally actually. So cardio and neuro usually, I usually have to conduct extra session always actually. All right. So no worries, guys. Let's take a break. We'll be back after 10 minutes. everyone. Let me know if you guys are ready to start now. I hope so you got an idea about the syllabus. We'll start with the medicine, which you already started. The respiratory GIT ongoing, then we'll finish the medicine, then there'll be general surgery, few classes, then there will be systematic surgery, ortho, I, ENT, relevant classes, then there will be gynae, then there will be obs, extended lot of sessions with theory, with recalls, and later we enter into a difficult part, which is psychiatry, which is quite new for many the doctors. And later we'll be finishing, there'll be ethical things and a lot of miscellaneous things actually. All right, great. And important update and information. We already started cleaning the group. So I think by next 1 2 days we'll be make a post. So those of you who are looking for a study partner, you can find it here. It's very important and essential to have a study partner in MC. It's not only for you must be a great student in your medical college in past you studied solo, but here it's not only about study, it's also about networking. Please remember this word. And you passed the exam, but you didn't get the job. Like, how does it feel? So, networking, remember, guys. So, networking, I'll give you an guidance and a lot of things, a lot of links in coming days, like where to apply job and this, that. We'll try have a small session in between the classes or in the beginning of the classes. And at the same time, you keep learning because we have time, 5 6 months, and there'll be classes ongoing. Please keep checking my YouTube channel. Those are smart ones. They also check my YouTube videos actually, and surrounding that is, you can also go to the official website, AFRA website, RSAGP website, and just keep searching, keep learning. And one day it's not possible; it takes time actually. Wait, with that note. So we start our next one. It's the stomach related or the relevant thing. Now let's just uh, draw a picture of like stomach right away. Can you tell me some of the diseases related to stomach? Okay, like starting with non-ulcer, uh, non-ulcer dyspepsia, then guys, duodenal ulcer, then gastric ulcer, then gastritis, then for drug induced or NSAID induced ulcers, then bleeding, bleeding peptic ulcer disease, then 6 cancer, anything, or all the things related to upper GIT bleed. All upper GIT bleeds are here. Anything, any bleedings? Yes, any bleedings are fine. Yes, very important. Like you can add pyloric stenosis. You can add two more things here. 7 PS pyloric stenosis in this manner, and also you can add the gastric outlet obstruction at the same time. Yeah, yeah. So another thing is important, like Zollinger-Ellison syndrome. That's something I was looking at. Then there's thing maltoma, this, that, many other things. So Zollinger-Ellison syndrome, you can keep it in mind. So it's another condition related to this particular area where abnormal amount of gastrin is being produced actually. Yes, Zenker's you can also add Zenker's diverticulum. Let's first start with, so we started in this way so that we don't miss the important anything. Zollinger-Ellison syndrome has been something tested in past actually. Okay. It's not given in John Murtagh unfortunately, but it's given in our SMA note. Um, if anyone not received after admission, I think in last 1 2 days, those are left over. We'll clear tomorrow. So you will find those things there in the drive. Coming to this one in the SMA note, let's see how Zollinger-Ellison syndrome looks like. This is how first it looks like. uh, zest, so much amount of gastrin is produced, first of all. All right. So gastric hypersecretion. So mainly Zollinger-Ellison syndrome, there's too much gastrin is produced, and it's a motility hormone. Am I right, guys? Please correct me if I'm wrong. Gastrin is a motility hormone. If too much gastrin is produced, it stimulates the parietal cell, and too much HCl will be produced. Now, is this too much HCl acid is good? Not really, actually. Are you expecting few ulcer? Are you expecting multiple ulcer? Because huge amount of gastrin produced, huge amount of HCl acid is produced. So we are expecting multiple ulcers. Zollinger-Ellison syndrome, multiple ulcers, most cases. Also, gastrin is a motility hormone. So if too much motility hormones are produced, it can lead to too much peristalsis, diarrhea. So in one-liners, Zollinger-Ellison syndrome, increased gastrin, increased HCl, increased acid, increased multiple ulcer, increased diarrhea due to increased motility, and very important to remember, main one, which I will teach you in the endo, main one association. If you have a cancer in one part, possibility of cancer in other parts, right? That's like the main associations. So Zollinger-Ellison, so gastric things hyperproduce, stimulate parietal cell to secrete more HCl. So clinical, these particular features, yeah. Oh, good news. I mean, is from very beginning that in our academy, any papers and things, because trade license and everything, we have it. So any paper, if you take after you pass MC Part 1, you can use it as an experience actually, or as better word is a CPD actually. Okay, so it's a good news for all of you actually. You can later claim 5 months. Yeah, yeah. So especially better to collect it after passing the MC exam actually, because before that you are not going to apply for job. So gastric pain, of course, because so much acid, so much ulcer, heartburn, ulceration, diarrhea, same things already, which I just have mentioned. Because of this gastrin, why too many, like too much gastrin? Because of gastrinoma. Now, this gastrinoma is like a tumor. So for gastrinoma, gastrin, then more HCl from the parietal cell, leading to multiple ulcer. So since it's a cancer, you need to give proton pump inhibitor to control the acid, higher dose in proton pump inhibitor, and because it is a cancer, you need to give chemotherapy. Interesting question. Uh, Therapy of choice in Zollinger-Ellison syndrome. Now, a lot of names are given: omeprazole, then ranitidine, sucralfate. These all are used in ulcers. There's another name given. Answer: PPI, because you need to control the HCl release mainly. So our answer would be omeprazole. Answer: omeprazole here. So keyword: multiple ulcer. A very important lines are given. You need to add this one in your list. The ulcer which is resistant to therapy. This note you don't have to take picture because it's there in the SMA note. Ulcer which is resistant to PPI. Like in spite of 20 or 40 proton pump inhibitor, the still pain continues. So you'll think either Zollinger-Ellison, or either you will think about a cancers. Okay, great. Quick question: is this thing is related to H. pylori? Is this condition related to H. pylori? Let's see your ideas. Is this condition is related to H. pylori? Yeah, you can ask for 150 CPD hours later. This is not related to, you know, yeah, this one is not related to H. pylori. Important information. This one is not related to H. pylori. So this brings us to the point. Let me share the screen again. Uh, Which one is actually related to H. pylori? Tell me some conditions related to H. pylori. So this one, H. pylori, H. pylori, H. pylori. These are H. pylori. This one too, H. pylori related condition. Also cancer, also maltoma, and many relevant things. But this one particularly, uh, yes. Great, everyone understood the thing. Can we go for the peptic ulcer disease now? Peptic ulcer disease, again, you can differentiate few things. Guys, let me know if you like drawing things. I mean, I'm trying to make a combination like drawing, John Murtagh, and the note. Please make sure, you know, you let me know if we're doing right or wrong. Okay. So gastric ulcer and one is a duodenal ulcer, right? We know, I mean, this is something we know from the MBBS. Sometimes confuses us. I remember gastric ulcer as a, hunger pain. Am I right? Hunger pain. So when we are in empty stomach, we feel pain. Full stomach. When you have so much food, then you feel pain. That's a gastric ulcer. So in which case do you think patient will lose more weight? So in this case, weight loss more. Because when you eat, you feel pain, so you don't want to eat. But that's one of the things. So less weight loss. Okay, or maybe some cases gain as well. But most cases stable, I think that's very important for AMC prospect. Now, the point I'm going to tell you, very important for AMC tested. Bleeding is more common in which particular ulcer? Repeat my things. Bleeding is more common in which ulcer? Perforation is more common. So perforation more than bleeding. In this case, bleeding more than perforation. Clear, everyone? So bleeding. Is this clear, everyone? In both cases, the diagnostic thing is endoscopic. This one is endoscopic, actually. So these are some of the major things or vice versa thing. Yes. So other points you can add like duodenal ulcer. When you eat it, the pain relieves, and vice versa in gastric ulcer, actually. Okay, is this thing clear, guys? Then we enter into the. So we just finished the basics on the pathophysiological thing. And already we discussed that, our stomach has parietal cell. Parietal cell helps releasing HCl. That is how acidity thing happens, and that acidity can leads to ulcer if not taken care of properly. Guys, conservative way you can always control the things actually. Yeah. Very important question. Ulcers can lead to cancers or not? Very important question. Is this thing can lead to cancer by any chance? The answer is a uh, yes, that is possible actually. That is possible actually. Also need to keep it in mind, some of the ulcers can be related to drug related, like corticosteroid can be important. Among them, gastric ulcer has more chance of cancer production. You can keep it in mind actually. So epigastric pain, often which is related to male, relief by for depends on gastric or duodenal. Dyspepsia is very common. We're at page number 454. Okay. So our main test for peptic ulcer to rule out ulcer or is it a cancer or anything, is an upper GIT endoscopy. Then, if needed, you can also do barium studies. Now, very, very important, another thing, and oh, by the way, one thing I forgot to mention, uh, that is, which one is more common actually? I think more common, less common. Duodenal ulcer is more common. This is something I forgot to mention. Okay, so endoscopy is the choice. Barium you can also do, and very important to rule out, H. pylori, right? Very important to rule out the H. pylori. They can certainly have a lot of complications too, like say duodenal ulcer can perforate more, gastric ulcer can lead to bleeding or as a form of hematemesis, as a form of melena. Some cases can lead to obstruction in a form of pyloric stenosis. Pyloric stenosis condition, by the way, I will teach you in the pediatrics. Okay. Then anemia, then cancer, especially please highlight this line. So you see GU, gastric, some cases esophageal stenosis, so please remember. And highlight the one H. pylori. Okay, talking about the H. pylori, again, let me open the investigation. Peptic ulcer disease, and we're talking about investigation related to peptic ulcer disease. What is the initial? What do you think? Let's say we are thinking, so choice would be endoscopy. This is our choice of test. Supporting can be barium, supporting can be anything. Now, uh, you think it's because of H. pylori. How to rule out the H. pylori? You know, urea breath test. Have you heard about this name? Interesting fact. So this urea breath test is a diagnostic and prognostic. What does it mean? When you diagnose something PUD due to H. pylori, what we give is triple therapy. Am I right? Triple therapy. Mind it, triple therapy can be not working due to resistant to metro or clarithrol some cases. Okay. So this was a AMC question in past. Reason of triple therapy not working. But anyways, about this triple therapy thing, how to see the prognosis? Again, urea breath test. Is it clear, everyone? So at the time of diagnosis, we are doing urea breath test here. At the time of the prognosis, we are also doing the urea breath test. Is this thing clear, everyone? Yes, after treatment, after approximately 4 weeks to 8 weeks, usually we do the test. Right? So this is something I wanted to add here actually. Ruling out the H. pylori is very, very important. If H. pylori positive, you go with, treatment for H. pylori. Okay. If H. pylori negative, treat with full PPI. Okay. In the next page, few things are given. This is the triple therapy, and highlight this line that some cases, next page, resistant to metro is very common. Clarithrol also increasing. Some cases it can be drug induced. Withdraw the offending agent. I repeat, withdraw the offending agent. Gastritis can be because of H. pylori again. So again, PPI, and some cases, you can add iron and vitamin B12 uh, additionally as a supportive. Gastritis is again confirmed with the endoscopy. Okay, this brings us to the point. Important one is the stomach cancer actually. Uh, Stomach cancer, there will be abdominal pain, weight loss, dyspepsia, abdominal pain, weight loss, dyspepsia, some cases bleeding in a form of melanoma. Okay, in some cases dysphagia as well. And very, very important, what we learned in the MBBS. Did you remember something like in the left, supraclavicular area, there's a lymph node checking is very important. What is that sign is called? Anyone remember that? There was a sign we call it actually. Sign or a triad or anything anyone remembers. It's called Varco's. Yes, Varco's sign or torsion. So Varco's sign actually. So left supraclavicular lymph node, it is indicating probably the cancer related and probably has metastasis actually. So one of the local metastases is this particular lymph node, higher chances. There's some risk factors are given. So I ask you guys to read esophageal risk factors. Um, Stomach cancer's risk factors are already given here, actually, as you can see. Okay. It is also important to examine well. You might find mass in some cases. And weakness, anemia, weight loss, these are very common actually. So stomach cancer, loss of appetite, weight loss, anemia, these are very common. Endoscopy of the upper GIT, mandatory endoscopic and biopsy. You can rule it out cancer. Wherever possible, do surgery. I repeat, build the surgery is called build road. His prognosis is good, not always. I mean, so you do the surgeries, and if it's stage 1 and 2, you can successfully remove it. Then yet uh, survival is possible. Otherwise, it's difficult. Otherwise, the radio chemo can be treatment. I haven't seen stomach cancer treatment coming in AMC. Most cases, it's a diagnostic question or some signs are given. Or one time a question came like this: which of the following is the uh, most common clinical feature of stomach cancer? I repeat my question. Most common MCC, like most common MC, most common clinical feature of stomach cancer. Now I'll give you option: weight loss, abdominal pain, then dyspepsia. So which one do you think is the most common in these cases? Final answer is a weight loss. Hmm. Weight loss. Actually, weight loss is the key significant point for stomach cancer. Please remember this. I'd like to show you a mnemonic if it's okay with you. Okay, so gastric carcinoma, stomach cancer, whatever you say. 5A, say for anemia, pernicious often. Achlorhydria, atrophic gastritis, adenomas. Okay, and blood group A type, very interesting. Okay, some relation Lindsay regarding this. A nice mnemonic related to all A. Okay. Most of the cancers are often adenocarcinoma. This is another important information. Of course, H. pylori plays a part. Also, those eat more smoked foods. Actually, did you know this information that area like Japan can have more cancers actually because the foods are not processed well actually. Right. So follow up by upper GIT endoscopy often used for the follow up. Okay, so we have done it, checking, going for the next one. So we just did the stomach cancer thing, and after that, we're going for the diarrhea things actually. Okay, in the diarrhea chapter, when we enter, we'll go into 1 2 page next, page number 420, 420 page. And this is also like a 420. Okay. So this one's name is pseudo membranous colitis, often known as antibiotic associated diarrhea. I'll start with a Q question. When you give that antibiotic, after how many hours or how many days the diarrhea is expected to start? Anyone? But that one you have to go to the next one. So mostly it will be watery diarrhea, and within 2 days of taking um, antibiotic, it starts, but it can be late as well. So usually, is it like a acute, like immediately after taking? Not always so acute actually. So within 2 days of taking, that is more common. So usually it will take like a 2 days to start, but can start up to even 4 weeks even some cases. Very interesting. All right. Number one thing, very important, is a similar kind of treatment thing. As you can see, cease the causative agent, that is the antibiotic. For this condition, pseudomembranous colitis, where diarrhea produced because of antibiotic, we give metronidazole. Some cases metronidazole can be resistant. Give vancomycin. Please be aware of toxic mechanism. Please highlight these lines, page 420 number page. Since we are speaking about diarrhea, there can be types of diarrheas like acute diarrhea, chronic diarrhea. I'm not getting into so much detail. These are MBBS knowledge, like what is acute diarrhea, what is chronic diarrhea. But please write it down so that those of you who have gap, you can review it. Nowadays, if you Google it, everything comes very easily. So, acute diarrhea, chronic diarrhea, watery diarrhea, watery diarrhea, bloody diarrhea. So please remember them really, really well. Also, some causes of gastroenteritis like diarrhea because of the gastric infection. Some names are also given here actually. So generally check these particular things. Pseudomembranous colitis is more important. Now, I want to know one thing which is important for our exam is which microorganisms. Here the microorganisms, by the way, I mean drug doses are not important, but microorganism names are important for exam. Now, which microorganism do you think will give rise to very fast diarrhea? I leave it to you. Which microorganisms, at least name two microorganisms that leads to very fast diarrhea, like within like a 1-2 hours of eating. Within 1 to 2 hours of eating, the patient will have diarrhea. Okay, one starting with Staph aureus. Staph aureus. Second, another thing, reheated fries rice. You keep it overnight, you reheat, maybe free in the fridge, the electricity is gone. So that is higher chances Bacillus cereus. There's another thing that salmonella, but it is not usually within 1 to 2 hours, a little later actually. I mean, more than 2 hours actually is salmonella. But from any chicken item, marinated chicken, if chicken is not cleaned properly, you might get salmonella. Remember that. Okay. That's why, sometimes some people say, oh my God, I eat household food. How come I get diarrhea? This, that. There must be something I ate outside. It's not at your home. The problem is there actually. Maybe you ask, or the collect the meat, maybe it's not properly cooked actually. Anyways, there's some other non-microbial food poisoning then that can be like mushroom. Did you heard these things that mushroom can be uh, leading to food poisoning? Yes, mushroom poisoning. Some beans, some cases even fish. Some fish can be very dangerous. Did you know this name? Puffer fish. I'm not sure. In our country, we call it like a different, another name of that fish. This particular neck side is quite big of that fish. Puffer fish poisoning. Okay. In Japan, it is a very popular fish, by the way. Okay. Anyways, there's nothing much here. General test for the stool, you go for a CBC, you go for a blood culture, you go for a stool test or a stool culture, if applicable, some cases. If it's a chronic diarrhea, you need to rule out celiac disease, you need to rule out other conditions too. Okay, I repeat the test for the diarrhea, like we go for CBC, blood culture, stool test, stool RME, simple blood test, and also rule out if any autoimmune conditions. Actually, it depends on acute or the chronic ones. Actually, uh, here is a line of things are given. Usually, we taught this one more in the pediatrics, but that's okay. These lines, please highlight, read at your convenience. Actually, example: colorectal carcinoma, which is part of our screening or surgery. Like there will be altered bowel habit, then there is a chronic diarrhea, and then there is a rectal bleeding. Okay, just very shortly they have written like colorectal carcinoma. Okay, some cases elderly age group, fetal impaction, and there's so severe abdominal pain. And when you do X-ray, you see the spots of fecal matters actually. So, anyways, read this part can be really useful. So this brings us to the point of malabsorption actually. This brings us to the point of malabsorption actually. Okay. Starting with the key point, how malabsorption happened and how malabsorption looks like. First of all, it will lead to diarrhea, but is this diarrheas are like watery diarrhea? I repeat my question. Um, in malabsorption, is this diarrheas are like a clean, like a watery or something like that? The answer is no. Because it's a malabsorption related thing, so fat things would be included. So there will be something related to which cannot uh, absorb the fat well. For example, some pancreatic problem, which can lead to malabsorption, celiac disease, again, then many other relevant conditions. So we call it often steatorrhea. Yes, someone is mentioned in the comment section. So bulky, pale, offensive, it's very offensive and grease like stool out which floats on the toilet. I don't want to tell more or I don't want you guys to imagine something in between nice class, something like that. Okay. So stool's difficult to flush down. So anyways, it's like a floating thing. All right. And because of losing weight, you started to lose weight actually. I mean, there'll be weight loss because of like vitamins and many other ingredients not absorbing properly actually. For small kids, there can be failure to thrive, like cystic fibrosis cases. No, there will be failure to thrive sometimes. Okay, and in the when you do the stool test, you will find more amount of fat there actually. All right. At some point, you might need small bowel biopsy. Why? Celiac disease-like condition, you will need small bowel biopsy. Conditions like celiac disease, which is our topic for pediatric, near to celiac disease, you can read it in advance. There is intolerance to some particular kind of food. Uh, so gluten-free food, actually. All you need to eat is a gluten-free food, actually. I will teach you that one in details in pediatrics for sure, actually. All right. Okay. And uh, you need to eat good gluten free. When you go to Australia, the super shop has very big corner of gluten free, right? Gluten free, lactose free. Right? Which one you need more? It's a general question, guys. Which one you need probably more? The gluten free or the lactose free? What do you think? You more need lactose free. 70% of Asian people are somewhere fully or partially lactose intolerant. For example, let me give you my example. I eat milk, one glass or any milk product, nothing will happen. But if I drink like a two glass, or say some of the event days like Eid days, we have to go to different relatives and everyone giving you some sweets or something milk product related thing, and then you have to keep eating, and then I start feeling like I have to go to toilet probably actually in the middle of the day. Okay, so no, like as I said, one dessert, no problem. Two, three dessert if you eat, if you have problem, means you have little bit lactose problem actually. Okay, so that's the reason in Australia I feel more comfortable. I remember uh, my post graduation time I had to stay in UK, so those bottles available, those lactose ones in UK, the milks are really tasty by the way. So those lactose-free ones, I mean, when I was drinking, I don't have any problem. Even I tested with a full, like a 1 liter. Yeah. So 1 liter I drink like in like a 1 hour, but nothing happened. But if it's the same thing, in my country, if I drink a liter, I will definitely have to go to toilet actually. So understood the point. So we probably need more lactose free. If you're living in Australia and if you're an Asian, try sometimes the lactose free one. If you feel comfortable with that one, it means it is true that partially you are lactose intolerant. Okay. Until proven otherwise, you are lactose intolerant, actually, fully or partially. Okay. Great. So, celiac, as I said, I'll talk more than this lactose thing just mentioned. Then coming to major things coming up, uh, inflammatory bowel disease. But before that, gastroenteritis. I mean, of course, diarrhea and fever. Is there anyone who never had gastroenteritis in their whole life? Yeah. I mean, starting from the school days. I never had. Okay, very interesting. Very solid tummy, I would say. Okay. I mean, it's just a normal diarrhea, actually. I mean, just a lot happening. It's like that. I think maybe you forgot. You know, I think, okay, you never know when you were a kid, you know. Because kids put something in their mouth and that's how it started, actually. Yes. Yeah, lactose is okay, my dear. I mean, you can just drink the lactose free. Even in the coffee shop, you can also ask them, okay, give me the lactose free ones, actually. In countries like Australia, in developed country, they don't charge more, I think, for the soya milk or the lactose free milk, actually. In our country, if you ask them, give me lactose free milk, they will charge you separately for that. All right. It's just, why we do things to make our life more comfortable, right? That's all actually. That's why we work, that's why we earn, and so that our life does not get monotonous over the time, actually, right? Uh, Interesting fact. Do you think, I mean, yet you all are become doctor now, I think planning to go to Australia. Yet, do you think uh, your best life did you left behind like in the school days? I mean, if you ask me honestly, no, maybe I'm at my top of my game or whatever this thing, but yet when I look back, I didn't have any stress when I was in school actually. uh, Even I used to have very small money, I mean, because it's a tiffin money was given, but I had whole day fun. I mean, even I was studious. uh, yeah, it was, I think, when I look back even these days, I think no stress and lot of fun, games, friends. Yeah, I think for us boys, even we were more allowed to go always, I mean, outside going to play. Yeah. But I think everyone's life is different. Okay. Coming back to the gastroenteritis, like you see, so diarrhea with the fever, actually. Yeah. We have to like keep our mind onto that one in case the diarrhea becomes chronic, actually. Now, can you give me some example of chronic diarrhea, which is more popular for AMC, actually? Gastroenteritis is straightforward treatment, actually. Normally, in the beginning, they might not give you treatment, but if it's not controlling, then they will give you the antibiotic in that case, actually, after doing the culture things, actually. Okay. Chronic diarrhea. Okay, cancer, you say, but before that, anything else? Let's say steatorrhea, maybe someone from Aboriginal area. IBD for adults is an important one. IBD, inflammatory bowel disease, ulcerative colitis, Crohn's disease is important cause of chronic diarrhea. Any malabsorption can be leads to chronic diarrhea. Pancreatic cause leads to chronic diarrhea. Parasitic, yes, now you're talking. Parasitic. So parasitic, very important to remember. Always countries like in Australia rule out the parasitic thing because in their food, it's very less likely in Australia that from the food you will get, unless you made it, I mean, by keeping in fridge, but in the shops, it's very less likely if you go to a chain shops, particularly. So, there's a popular condition like this Giardia lamblia, a badminton shaped parasite. Remember in the parasitology book, a badminton shaped parasite? So this thing can be dangerous, and all the classic features of like stoturia, bulky stool, float on the toilet, very smelly, all these things are applicable there actually. Okay, great. So please remember Giardia, Lamblia, keywords aborigine, keywords chronic diarrhea, keyword malabsorption. Okay. And last thing, how to treat this condition. All this thing has been tested in AMC. How to treat Giardia. Answer, metronidazole. Giardia treated with metronidazole. Please remember this well. This thing I'm not gonna teach here actually, nothing really. Assessment of dehydration, mild, moderate, severe, and treatment of mild, moderate, severe. Everyone who has become doctor, I'm sure you know. Even non-doctors also know some cases. So this part I'm not really gonna tell more, but you can just highlight this device one time, this chart from the 428 page. Now I'm taking you to more chronic diarrhea. Toddler's diarrhea is one of our topic for the pediatrics actually. Kids from 1 year to 2 year, 3 years age group, they often develop some diarrhea that can be toddler's diarrhea. This brings us to the point, some chronic diarrhea. So Giardia, entamoeba histolytica. Now entamoeba histolytica, I remember in AMC it was given like this, that someone traveled to a different country and after coming back after a few weeks, they also have this diarrhea and this that. So in that particular cases, they can develop, and liver can be also involved actually. So that's a entamoeba histolytic actually. So you see, highlight few things: chronic enteric problem, Campylobacter, Yersinia, uh, Salmonella. I will cut it out actually. Not commonly, it's given actually for chronic cases. Yersinia, Giardia, and entamoeba. Out of them, Giardia and entamoeba histolytica has been tested. Campylobacter actually tested in relation to other disease which I will teach you in the rheumatological conditions, like if you know a conditions like Reuters, or also in neurology like in GBS actually there will be like a prodromal of diarrheal infection like 1 to 2 weeks back. Yes. So this Campylobacter word as a compare contrast, I will relate during the neurology classes actually, or maybe the raters cases actually. Yes. All right. Celiac, as we mentioned, I mean, nice to know for, I mean, now, but it's important topic for pediatrics actually. And traveler's diarrhea, in one word, which is the culprit for traveler's diarrhea? Main culprit for traveler's diarrhea is usually the E. coli. Usually the E. coli. Okay. I will uh, like to add one more point. That is the hemolytic uremic syndrome as well, to remember, even the pediatric topic a little bit. So, in relation to traveler's diarrhea, also double check that word hemolytic uremic syndrome. Do you remember the strain of hemolytic uremic syndrome? I don't Let me check if I have this one. So you see, prodrome of gastroenteritis, fever, bloody diarrhea, this, that, and it is associated with renal failure as well in seizure some cases. Many cases you'll find edema and hypertension too. Hemolytic, yeah. So hemolytic uremic syndrome. So there can be bloody diarrhea. The situation can become severe and she become lethargy. Vital can get affected with a patchy things in the legs. Important characteristics, she has abdominal tenderness. So hemolytic uremic syndrome has abdominal tenderness as like the other gastroenteritis, which is common. But key word would be, you see the creatinine, so acute renal failure. So The diarrhea with the acute renal failure and sometimes rash plus minus can be hemolytic uremic syndrome. Okay, so this one can be tested. Yes, you can do stool culture in these cases. You can do stool culture in these cases. Okay, just write this word, hemolytic uremic syndrome. As I said, by the end of the medicine, I will give you a little touch, few things related to travel actually. Any diarrhea cases, first maintain the IV fluid level. Very, very important. If vomiting, give the symptomatic treatment for the vomiting. Next, this brings us to the point, some of the microorganism name and their treatment. I'll highlight few which you need to remember. So Salmonella shigella, like ciprofloxacin, just highlight it. Giardia, Metro, again Salmonella, Cipro, Campylobacter, Azithro, Enterohistoderm amoebiasis, Metro again, typhoid ears, first week fever, Cipro again, and Azithro too. And cholera even does not much tested nowadays. Again, azithromycin can be good choice. You don't have to remember the doses for ANC. Okay, great everyone. Understood the diarrheal things. So diarrhea, again, I'm highlighting acute or chronic diarrhea difference. That's an MBBS thing. Then causes of watery diarrhea, causes of bloody diarrhea. Then assess the dehydration. Do some tests like CBC, blood culture, urine stool culture, these things. If needed, rule out antibody things like celiac disease if necessary, or giardia if you feel chronic diarrhea. There can be some specific tests. Okay. And in adult cases, also rule out some autoimmune things like if there is inflammatory bowel disease relevant things actually. And as per the different microorganism, you treat accordingly, which we just now saw, right? Also, be aware of malabsorption. Malabsorption is stool uh, characteristics can be little different. Like there will be smelly, greasy, floating on the toilet. Often can be because of parasites. In Australia, the word aborigine can be mentioned, or maybe a recent migrated from somewhere like Australia or like in somewhere like African countries or Asian countries, even from the China. Yeah. Uh, from China, parasitic infections can be very common because they eat a lot of, you know, raw food actually, or uncooked properly actually. Even the COVID thing, you remember, I think started in the China, right? And many people like to eat bat even actually. Yes. All right. So I think last all of them almost you have to remember at least one of the names for that actually. Don't worry, we'll be uploading the recording so you can also cover up if you miss anything. All right. Next, we're going to start. We are getting into the colon, but not the surgical colonic things, but mainly medicine related colonic things like inflammatory bowel disease. And inflammatory bowel disease divided into ulcerative colitis and the Crohn's disease. Now, before getting into this one, let me ask you guys, what do you think in case of inflammatory bowel disease? What do you think, guys, is the common features? So, commonest features of inflammatory bowel disease, other than the diarrhea, and even if it is diarrhea, what kind of characteristics thing are you expecting? Please comment in the comment section. Yeah, let me bring out the note related to inflammatory bowel disease. Just give me a second. Yes. So ready here, inflammatory, some of the bowel like Crohn's and ulcerative mainly. Two types, Crohn's and the ulcerative colitis. Few universal features for both. So, like a bloody diarrhea is one of them. Abdominal pain, diarrhea, which is a bloody diarrhea. So, rectal bleeding is mentioned. Weight loss often been mentioned. And often, if you treat that one, they often come back. That is the main problem. Why? It is unique and different than other diarrheas. Even if you treat, there is a remission phase. Please write it down in your journal. So there is a remission phase. Clear, everyone? We don't like any disease which has the remission. Can you mention any other disease which has remission or the history of coming back and hitting more badly? Any conditions like maybe a neurological condition? Rheumatoid arthritis, good. Leukemia, okay. I mean, more classic. Multiple sclerosis, my dear. No, I mean, TB comes back, may not hit that hard. Multiple sclerosis in second decade and then in fourth decade. They hit really hard in the fourth decade later. Isn't it? Yeah. So more correlated like flare up and the remission thing. So IBD, also remember multiple. And also they are multi-system conditions, same as the rheumatoid arthritis as well. Isn't it their multi-system condition? Yes. So goes with the SLE as well. Isn't it their multi-system involvement? Yes. Okay. Very important to correlate. IBD, you need to check the um, colonoscopy thing you have to do. At the same time, later you have to do some other tests too, actually. Yes. Coming to the more points, you have to use certain drugs for IBD cases, which I'm taking you now. Yes. Treatment. So generally, let's go with the treatment for both of them. Of course, lifestyle modification, support group. Sometimes you see the what support groups are mentioned. We are not much familiar with this. Those of us are working here in our countries. Support group is like a community in those countries. It's very common for alcoholic their communities, smoking, quitting communities, IBD communities, cystic fibrosis community. So the support group, the candidates support each other. Like for us, during the exam, we call it support group. Even in our classes, I highly recommend you guys to stay and connected with each other. You can send a friend request. If someone has a visible ID, you can send a friend request. Stay connected because those of you who are growing together now, at the some point, all of you will be together searching for the job. Okay, so those are more better connection with friends. Eventually get the job more early or learn the process of job hunting more early because it's keep changing the sequences actually. So the support group, it's here. Your MC support group is in front of you. Those of you who are attending classes, you all will be friends at some point in Australia and you will be together. Understand? Trust me, now I see a lot of pictures uh, with nowadays actually sometimes I cannot add more people because my 5,000 in Facebook been crossed long back now. But those which I used to teach when like initial days, many I used to know even personally, been and stayed in Australia. Sometimes I went to some seminars with them. Clicked few actually. Now I see like those studied before. Many of them are also friends in Australia. Attended seminars together. Yeah, sometimes they also send pictures. How are you doing? To see all of us together. So it's fun actually. They stay more connected actually. I think the connectivity were a little bit more, I think, when we go back 7, 8 years back actually. Or maybe, you know, over the time I might also become busy actually. So I cannot blame anyone actually in that way. Yeah. Okay, coming to this one, support groups and support groups are important. You guys will have exam support group from us. During exam, we give a lot of support to our students. That's why we are popular. Coming to the treatment of IBD, ulcerative colitis or Crohn's, here is a thing. Sulfasalazine is the one of the mainstay. Please highlight this particular line. Sulfasalazine, mainstay of treatment. One of the Then there are other things you can add like methotrexate. I have also seen this coming in the exam, even though not sure where it is mentioned. But methotrexate is another one as a next level treatment, and also azathioprine, which is called immune modifying drugs actually. So sulfasalazine, initial mainstay, then you can add methotrexate, and then azathioprine. You have to remember this sequence actually. If you want, I can write it down in a nice way. This part is really important. So IBD cases treatments. So inflammatory bowel disease. Okay, so the treatment, let's say initial. So in initial treatment would be sulfa, salazine. Next, it can be MTX, even though not mentioned in John Murtagh well, but it comes in exam often. And initial next, and then best or like a last resort, better word, as a third print, also called immune modulator. Now, you must be thinking about, doctor, where is steroid? Okay, where is steroid? Now, steroid is given in acute flare-up, no matter in stage 1 or stage 2, sorry, stage 2 or stage 3, any point you may have to give steroids. Understood? Whenever this condition flares up with abdominal pain and with the other features actually. Okay. So in that case, definitely you need to add, because IBD is an autoimmune condition too. You must be knowing, for all autoimmune condition, corticosteroid you have to give it. All good, guys? Wonderful. Yeah, methotrexate is also here actually. Okay, great. I'd like to show something. Okay, so more continuous with ulcerative colitis, Crohn's, diarrhea and mucus, bloody diarrhea and mucus. This is very common line. Here is a special line to remember: area of friable mucosa. Okay, you need to remember a special line. Write it down near your John Gupta, taken from another book. Area of friable mucosa. It is characteristics for ulcerative colitis. Now you can see a few more things about ulcerative colitis. Both of them have pain, weight loss. These are common. So see, this is normal. This is Crohn's. Crohn's has all four layer involvement. So the lumen become more narrow, whereas ulcerative by name, ulcerative ulcer. So multiple ulcers out there. Also, a lot of pseudo polyps out there. Whereas because of all four layers involved, Crohn's has cobblestone appearance. Okay, this is interesting. So disease has like abdominal pain, diarrhea, mucus, and they lost a lot of things, so they feel fatigue. So initial treatment, sulfa, acute flare-up cases, steroid, refractory treatment failure cases, azathioprine. This is how to, yes, okay. Acute flare-up cases, steroids. Remember, in that way, you'll get to see more in the exam. Now, here is a differentiating table, I would say. I've been teacher for long. I mean, uh, even in China, I used to teach actually. There was a medical in the Jiangxi. Anyone from any Chinese medical here? I mean, staying in China in past, or medical colleges in China? Anyone here? Okay. Anyways, um, so Jiangxi is one of the uh, areas, and I used to teach in Gangnam medical, which I visited recently as well. Actually, there was an invitation from the medical. Actually, I went to see meet a great, actually, some old colleagues, always refreshing, nostalgic. Um, yeah, great. They're also happy to see me progressing, actually. That time it was like my kind of first job in abroad, actually. Yes. All right. Now, why are you reminding that one, actually? I mean, that time when I became teacher, I was very young, actually. Just after MBBS, I just quickly appear in one of the degrees in 6 months. 1 year, I finished it very fast and then joined there. Then I will start preparing for the AMC, actually. Great. Now, uh, I was young and they were also young too at the same time, but I sometimes tell them not to smoke and this, that. I used to seize their cigarettes sometime, actually. And those Chinese uncles or security guard, they call Susu, I think, or something like that. So I used to give their cigarette to them, actually. So they used to make fun. And now there was a play in one of the event. So they said that in that way, did you know Dr. Sherry recommend to smoke? And I was also surprised. I usually recommend not to smoke, and now they're telling, okay, we recommend you smoke. That's the second part of the drama. They're saying, yeah, it's because if you smoke, you will not have ulcerative colitis, Parkinson's, Lewy bodies, actually. As a fun fact, I was telling that here is a little information for the smoker. So they pick that one, whereas the other 400 diseases can happen. They skip it in the drama. So my vice dean was also looking at me. Did you say that? And I was they're making fun. All right. So here's a fun fact. Again, even in our class today, I'm sure there must be few smokers. So here is a little good news. One of those conditions like ulcerative colitis probably will never have, actually. So risk-free from ulcerative colitis, Parkinson's, maybe some dementias as well, actually. All right. Anyways, ulcerative colitis, superficial mucosas, Crohn's is a deep, that's why cobblestone appears. Ulcerative colitis has more ulcers, more pseudopolyps. Crohn's disease has more thickness. So here is the point, very important for MC, which one can lead to bigger complications like obstruction, like stricture. This problem will be related to which one more, Crohn's or ulcerative? It's Crohn's because Crohn's has, if I, um, if you've seen this picture, Crohn's has all four layer involved. So the lumen becomes more narrow, more narrow lumen, more chance of obstruction, stricture. So more chances of complication, more chances of complication. Okay. So stricture, fistula, obstruction, these are more common. Both of them, because it's kind of same disease, inflammatory bowel disease, there will be systematic features and other system involvement. Okay, so read them at your free time. So GIT, I remember these things as the GIT and non-GIT involvement. Same goes for the rheumatology, rheumatoid arthritis, uh, arthritic features, non-arthritic feature, actually. So you can remember in that way. Okay, so toxic megacolon, more chance with ulcerative colitis, whereas fistula, obstruction, cancer, some of the even stones, more chances with Crohn's disease. Treatments are almost similar, nothing much difference here. Okay, did you get a clear view of inflammatory bowel disease now, guys? Do you have a clear view now about inflammatory bowel disease? I think if you keep digging now, I think so. Here is a very important tip of the day. It's more important you finish the theory things in next 1 2 days because before it washed away from your brain, the class things, actually. As the time progresses in the live classes, try to absorb everything, write it down, mark the book so that you don't have to see the recording always. There is a group of people, they attend live class half-heartedly, then for 2 days they are just checking the recording, then again another live class came, they don't do their personal studies more, and that is a very wrong practice. Okay, the good students in the beginning they see some of the recordings or they keep their study partners, actually. So whatever they miss, they ask their study partners at the time of discussion next day. They don't go for the checking the full recording. It's a waste of time recording checking unless it's a very tough topic like neuro, cardio checking, recording it. But every classes, if you have to check, double check, triple check the recording, then when you will study your things actually, because you not only have to study these things, then there is certain question banks will give you, you have to study that. Okay, then from the forums like Shahriar MC guideline forum and some other forum, or in between partners discussion, I mean, all together is the complete preparation, dear doctors. Okay, I hope you understood what I'm trying to say. Yes. Now, not every time. See, if something is totally clear, say uh, inflammatory bowel disease, it will appear to you if you know most of the things or not. Yeah, you understood everything. Now, then you go to the recall class, something will be clear. Now, if you find anything complicated later, that thing you should check now RSCGP, or you are not finding any reference for a particular tough question. Only that part you see from that RSCGP, or first check always the John Murtagh book. If it's available, if it's not available, then you check into the um, references from the RSCGP. Mind it, sometimes ChatGPT is good, but ChatGPT has 25% of error often, especially putting MCQs and then answering it can be catastrophic actually. And it also halts your ability at the same time, So this is the new generation. AI is there, but how destructive it can be, because in the exam day there is no AI, nothing. It's you, the only human body, you and your soul would be there in the exam hall actually. And it's a 3.5 hour terrified, exam. And they're also going to increase the bar, going to make it even more difficult now next year. But you don't have to worry. I mean, if the all the points I said, I mean, different time MC has been changed a lot actually. We did never bothered. Our passing rate was always good actually. So you have to only thing that can save you in the exam if you study really well actually. And for that, please follow the instruction. I'm probably the experienced most dinosaur teacher maybe in MC. That's okay. The thing is, it's just, I mean, I started so early teaching actually. So, and have been following everything. So I know that, what pattern they're gonna change. Yeah, great. So best possible idea. You will go for exam next year, of course, after July, probably. So I can tell you the changes by the time because they officially said uh, in the April 2026 they will make changes small. So we'll get to know those changes. We always crack down their system. Don't worry on that one. Okay. Yeah. All right. So ask your question. And IBD, is it clear? Inflammatory bowel disease is clear. Now coming to the very sweet topic, IBS, actually, inflammatory bowel syndrome. Same thing like the IBD, lot of things, abdominal pain, malabsorption, some cases. But bowel habit also changes. And in these cases, there is a phase called alternative diarrhea and the constipation. So let's see what is mentioned here. IBS also has note, by the way, so don't worry. So abdominal pain, bloating, uh, gas, diarrhea, and sometimes constipation. Either it would be diarrhea phase or a constipation phase, actually. Can be a chronic condition often. Symptoms can change over the time. Very important information. Very, very important. Symptoms like days, weeks, months to develop. Okay, severe abdominal pain can be, or overnight symptom can be troublesome. Okay. This is a list. I think I took it from the Oxford, I think, medicine, because it was given well. So depends on the diarrhea phase or constipation phase. You have to choose a. Say if the patient is going through diarrhea phase, it's better you don't choose a laxative that particular time. Okay, so you have to choose smartly actually. So other than the constipation treatment or a diarrhea treatment, you also have to choose an SSRI. This is very important. In IBS, other than the bowel changes, habit changes, there is mental changes also there. So in order to treat that one, you need SSRI like conditions like fluoxetine, will be a very good choice for the IBS. This can be a very good choice on IBS. Uh, Here is another thing. Interesting point, even though diarrhea, but not associated with any blood. So a condition, abdominal pain is as common as IBD with IBS, but diarrhea or the constipation, or some cases both can be together, rare cases. IBS, another thing not associated with weight loss. Very, very important information. Pain in the IBS is relieved by bowel movement. So when they pass stool, they feel better. Less at night, relieved by change in the bowel habit. Treatments are given. Fiber in the diet, antispasmodic drugs, antibiotics, and SSRIs actually. All right. Everyone, please mention in the comment section, is it clear so far? IBD, the IBS, two chronic conditions. Are they clear to you now? All right. Is this problem with you guys? I'm not sure you have. Where is your mobile you put? Where you put your uh, watch sometimes? Is this thing common with you guys sometimes? And also those of we us wearing the glass sometimes at the time when we're going out, why we put our glass? That's the last moment. Yeah. The good thing about uh, the iPhone and the Apple, they have some devices you can track. Like example, just right now I just tracked my mobile I hope nearby. So it's like that. And even there are small trackers for the kids you can use, by the way. Sometimes you are worried about your kids. So for your kids, you can use a tracker in their bag. I mean, small kids, this that can be a good idea. Some cases actually. Anyways, all right. We're almost at the end, so I don't want to bother you more. Already mentioned about upper GIT bleeding. We mentioned already, right, guys? There's a topic, upper GIT bleeding. Remember, everyone, please comment. I know everyone tried, but we are finishing in next 5 minutes. Yeah, respiratory mock not held today, but your bigger loss you are late 30 minutes. Okay, so these are the uh, upper GIT bleed. We have got upper GIT bleeding earlier in the day. We have covered. These were the causes of upper GIT bleeding things. Okay. Now in this another side, if I just want to highlight the lower GIT bleeding things. By the way, esophageal bleedings are also upper GIT bleeding. Don't forget that. Now, which part do you think is this? Separating upper GIT and the lower GIT. Area of travel related to ulcerative colitis, just a keyword. Okay, coming to this one, this is lower GIT bleeding. This is a ligament of Treys. Ligament of Treys something. Any bleeding from above this is upper GIT. Any bleeding from below this part is a lower GIT bleeding. That means this, you know, some part of the duodenum, stomach, even esophagus, these all related to upper GIT bleeding, and the mostly uh, small intestine, large intestine, this part bleedings are lower GIT bleeding. Lower GIT bleeding. Now, tell me number one cause of lower GIT bleeding. That will be surprising. Many said it is hemorrhoid, but not hemorrhoids. It is diverticulosis. Then what? Anything? Okay. Polyp you can put, but maybe later. Angiodysplasia, angiodysplasia. Then comes the piles of the hemorrhoids, then fissure, cancer, then so as the other things. So popular question. So diverticular disease and the angiodysplasia, maybe you remember. And as you all can see, so medicine, M for medicine, GIT. You just go and you'll find the lower GIT bleed things. All right. So below the ligament of Tay, the bleeding. So diverticulosis, polyps, IBD, colon cancers, hemorrhoids, fissures. Yes, diagnosis includes sigmoidoscopy. I mean, first of all, physical examination, rectal examination, then colonoscopy or sigmoidoscopy, more recommended. Then treat accordingly, resuscitation, blood transfusion if needed, actually. So lower GIT bleed. Uh, Number one is diverticulosis, anatomic often. Vascular is angiodysplasia. Then the cancer and the inflammatory. Inflammatory is IBD and IBS. IBD mainly IBD. Yeah. Ulcerative colitis, Crohn's disease. All right. So upper GIT and the lower GIT. Yes. There's another thing, mesenteric ischemia. Mesenteric ischemia, I will teach you guys more in the surgery. It's a more surgical condition, often connected to arrhythmia and some cardiac uh, things. Actually, I'll teach that one in the surgical. Yeah. All right, everyone. So that's the end slide for us. Hope you enjoyed the GIT and hemorrhoids, anal fissure, rectal cancer, or colorectal things we'll cover in surgeries. Actually, those are our surgical. Hemorrhoids is mainly surgical things. Actually, fissure as well, anal fissure. Actually, we treat it with calcium channel blockers and many other things. Yeah. So that's all. I've been from the medicine part of the GIT. So we focus more on the certain oral cavity, certain things we also discuss in surgery, like especially salivary gland things. Okay? In the surgery, we'll discuss about the salivary gland related few things actually. Great. Thank you so much for attending the session. And now I think there will be a mock respiratory coming up. I'll guide you a little bit on that one, but this is the end of the surgery theory class actually.